so we're going to pick up with the second half of the joint mobilization lecture here. So we had just finished talking about the different grades of mobilization, and we went through the differences between grades 1, 2, 3, 4, and 5 for joint mobilization. So this kind of sums it up again. Grades 1 and 4 are going to be more of your rapid oscillation, so your very small movements within either the available range or the beginning of the range, or grade 4 is going to be at the end of the range. Grade 2 and 3 are going to be longer, slower, smoother oscillations, and you're going to do them for a little bit longer. You're going to vary the speed, again, for different effects. So slower speeds for relaxation, you can use the higher oscillations kind of for pain. We do want to distract the joints before we start to mold them. So if we're talking about a shoulder, you want to try to pull along the long axis of the humerus just to try to distract it so that you do get some nice movement within the joint capsule there. So mobilization with movement, again, or mulligan with movement, is another way to potentially mob joints or to increase range of motion at a particular joint. We do want to use pain as our guide and not go past the point of pain, and we shouldn't be causing any pain with the movements that we do. So again, it should be painless. It should result in improved function. This technique uses osteokinematics and arthrokinematics. So we're going to use a little bit of distraction with a little bit of movement. Again, this is where you often see that seatbelt being used. And as we go through the different joints here at the end of the lecture, I've included some videos for what a mobilization with movement would look like for some of the common joints that we use that with. Okay, so shoulder, the glenohumeral joint. This is probably the most common joint that you're going to see joint mobilizations used for. So we typically have the patient relaxed in supine. The scapula is going to be stabilized just because they're laying on top of it. We are going to place our hands just distal, sort of, or on the distal part of the humerus. In the video for the I think it's the posterior and the anterior glide. It's the same gentleman who does both of these. I do like his hand placement and the way that he explains it. He kind of tucks the patient's arm against his side, so in between his arm and his ribs to sort of stabilize it, and then he has his hands to be able to do the mobilization. So these videos, I have videos for each of these to show you just typical joint mobilizations. We inferiorly glide at the shoulder to try to increase the inferior joint capsule space, and that's going to help to increase abduction. So again, based on what your patient's coming in with and what limitations they're demonstrating, that will determine what type of joint mobs you're going to do with that patient. Posterior glides are going to be performed. They should help to increase flexion and internal rotation. And then anterior glides will help to increase extension and external rotation. So there's a couple ways you can do anterior glides. Again, in this video, the therapist is showing you how to do them very similarly to the posterior glides. He's basically doing them both at the same time, anterior to posterior, which can certainly be done. Another way is to actually have your patient roll over into prone and then do an anterior glide exactly how you would do a posterior glide with your patient in supine. I typically don't do anterior glides as much as I do inferior and posterior glides. Again, your flexion and abduction are oftentimes limited just because those are over shoulder height motions. And so those are going to be addressed through your inferior and your posterior glides. But absolutely, if your patient's lacking external rotation, you need to do some joint mobs to help with that. You can do some anterior gliding to help. So the one thing in these videos, I don't think they go through and show you a lot of the differences in the grades of mobilizations, but you will get an idea of what the patient position looks like, what the therapist hand placement is going to look like, and what those mobs are going to look like in general. So it gives you a good foundation. The elbow and the forearm, there's a couple ways to do these. I don't typically do a lot of like grade 1, 2, 3, or 4 mobs with the elbow. What they are showing in this picture is they're using sort of that seatbelt to stabilize. So what they're showing is more of a mobilization with movement, or one of those mulligan techniques at the elbow. So they're fixating the upper part of the arm to the table, and then they put their hands over the lower part of the arm. So again, if you think about the arthrokinematics at the elbow, how the humeral head is coming down and then it sits in that big deep cup of the olecranon, you got to kind of scoop out the lower part of the arm to start bringing the elbow. And what she will do in this picture is as she scoops and pulls down on the forearm, she'll bring his arm up into flexion by having his arm rest against her shoulder. Again, this is not one I use a ton, but it does help to increase elbow flexion. And we did talk about why it's important to have full elbow flexion back in the elbow chapter. The wrist, basically what we need to do at the wrist is you are going to basically just take your patient's wrist, and if you squeeze it, so you can try this on yourself, put your fingers around your wrist and squeeze. You can kind of feel a little distraction there in the carpal area. Typically what we're trying to distract is like the carpometacarpal joints, and then from there, so you use one hand to distract, and then you could use your other hand to do like either dorsal or volar glides, so moving up or down to increase wrist flexion or extension as needed. So a dorsal glide is going to increase flexion, a volar glide is going to increase extension. Okay, so the hip. You can mobilize the hip with grades 1, 2, 3, and 4 MOBs. Again, depending on which way you want to mobilize will depend on your patient position. So an inferior glide is going to be used to increase flexion or internal rotation. An anterior glide is going to be used to increase extension. Typically for those, you are going to have your patient positioned in prone to try to get to the hip joint itself. And a lateral glide to distract the hip should be applied in order to sort of increase that joint space and actually make sure you're getting some mobilization. So in this picture, and what the video shows you is what I probably more commonly do at the hip is a mobilization with movement. So what they're doing is the therapist uses the seat belt, or we also use gait belts sometimes if we don't always have seat belts, and wrap it around the patient's upper thigh and then around their body as well. So then what the therapist does is kind of sits back a little bit to apply this distractive force. What we're really trying to do is try to pull the femoral head out of the acetabulum a little bit, just enough to distract it and give them a little bit more joint space. And then what we'll do is the movement part of the mobilization with movement. So this is the mobilization, and then the movement is we'll move the patient into flexion or move the patient into internal or external rotation. That's shown in this video here. And I think they do a pretty good job of demonstrating what that's going to look like. So the idea is we get some joint distraction and then we add some movement to increase movement where the patient is lacking. The knee, typically we're going to position the knee in about 25 degrees of flexion, again, because that's the open pack position. That's going to gap the knee a little bit and give us a little bit of room to move. We can do a posterior glide to increase flexion at the knee or an anterior glide to increase extension. Again, the knee is one of the ones we don't do glides or MOBs quite so much to increase knee flexion or extension, as we will probably just do some passive range of motion. What we do a little bit more at the knee is maybe some patellar mobilizations. So a lot of people call these patellar glides or patellar range of motion so that they're not considered truly mobilizations. For me, I can kind of go along with that unless you're really following the rules of joint mobilizations and you're doing just really small oscillations within the range and then longer, slower motions, and you're doing the grades 1, 2, 3, and 4, which isn't how we typically glide a patella, then it's not quite the same as a joint mobilization. So in this video, which is titled Patellar MOBs, it's a physician showing how to do patellar MOBs. You'll get a pretty good idea. It is more just sort of range of motion of the patella. So it's gliding it medial laterally, gliding it inferiorly and superiorly is typically what we do. So inferior is going to help to increase knee flexion. Superior is going to increase knee extension, hopefully. And again, medial and lateral is just to keep that patellar moving and gliding so that it doesn't restrict any motion. The foot and ankle. So we can do, again, grades 1, 2, 3, and 4 MOBs at the ankle, where typically we will stabilize at the tibia and then we'll put a hand underneath the calcaneus to glide, or up on top of the up underneath on the calcaneus to glide anteriorly, or up on top on the talus to glide posteriorly, or mob posteriorly. Posterior glides will help to increase dorsiflexion. Anterior glides will help to increase plantar flexion. Again, probably more common than just straight joint mobs at the ankle. I will do this mobilization with movement with the belt. So the video shows pretty much what they're doing in this picture here. So again, we're using that seat belt to sort of stabilize on the lower part of the leg. The therapist then wraps that around himself, and then he's using this upper extremity to stabilize the foot part. So he's got his hand kind of domed over top of the talus there. And then what's going to happen is the patient standing up here on the table is actually going to lunge forward and force more dorsiflexion into this. And by doing that, and with the therapist stabilizing here, that's going to sort of force into a posterior glide here by bringing the knee up and forward, which increases dorsiflexion as well. So watch this video and you'll see a little bit about that as well. All right, that's it, guys. Thank you.